Thank you very much. The acknowledgement should go to Taro Takahara, who's the inventor of whole body MRI scanning, and taught me a lot of what I know. So you'll already see there's a typo here. Siemens is now called Healthineers. Did you hear about that? And there's 2 E's apparently. Okay, so let's start with the patient. Here's a patient at high risk of breast cancer, a BRCA2 carrier, and she gets all the regular treatments that she should do. She presents with sternal and chest wall pain and has a bone scan, which is the standard of care. And you can see one lesion here, another lesion here. So anterior view, there's another lesion here posteriorly on the right. This is the posterior view. So she's got metastatic disease, which of course is bad news. But what I'd like you to do today is to concentrate on this left iliac bone lesion. Here it is as an area of osteolysis. Here it is on a B900 image, but not really visible on the bone scan. Now, why did that happen? Right? Why did that happen, and is it unusual? Well, if you do a lot of multimodal imaging in bone disease, you see a variety of patterns. And essentially, they divide up between low cellularity and high cellularity. And the low cellularity patterns can be osteoblastic and dense, but can also be osteolytic. Now, some of you will say, hang on a minute, there are holes here. How can you say that's low cellularity? Well, it turns out that there is about 35% of multiple myeloma that looks like this. It's got holes, therefore it's multiple myeloma, it's osteolytic, but the PET scans are negative and the diffusion scans are negative. So you do get this pattern, and there's a reason for this. No time to discuss it today. You've got the high cellularity spectrum, and the high cellularity spectrum ranges from this ground glass appearance, so-called osteoblastic or osteosclerotic pattern, to this osteolytic pattern, which is at the other end, with a normal pattern being in the middle as well. Now, whether these lesions are positive or negative depends on the cellularity and the bone response to the cells within the marrow space. And I've just laid out to you what they commonly look like. Now, so the question is, why do we see this? Well, if you want to answer that question, the first thing you need to know is, what is imaging depicting? So if you look at the marrow space, it's a complex organ, and most of us just ignore it, but it happens to be there. We just say, forget about it. Now, if you look carefully at this space, we have technologies that can look at different compartments. So diffusion imaging will look at the cellular content. CT scans will look at the bone itself, and therefore the osteoclastic activity. If you're interested in the activity of these osteoblasts, then you would do bone scans or sodium fluoride PET scans, for example. If you were interested in the tumor, then you could be much more specific by using tumor cell specific markers or cytoplasmic markers such as FDHT, PSMA, etc. Or you could use non-specific tumor markers such as FDG PET or choline PET, etc., etc. And then by combining information from all these modalities, i.e. multimodal imaging, you can develop an understanding of what you see. So here's 2 women, slightly different ages, slightly different histologies. So this patient has lobular carcinoma, this patient has an invasive ductal cancer, both in breast. See, both of them are sclerotic, except this is uniformly sclerotic. You'll see this is a bit osteolytic and osteosclerotic. If you look at the FDG PET scan, you'll see that this is metabolically inactive. This one is metabolically active. If you look at the cellularity is high here, and the cellularity is high here as well. So again, demonstrating similarly that there are these different patterns one can see depending on the modalities one uses, and that's very informative and tells you what you should be using for follow-up. So in this particular patient, you certainly should not be using an FDG scan for a follow-up. You should be using diffusion. In this particular patient, you could use FDG PET scan, or you can use diffusion imaging. Not a problem. Both of them will be effective at follow-up. Now, why do you see these patterns? Another way to put it is, what are the interactions that occur between tumor cells and normal marrow and bone marrow mesenchymal cells that lead to this osteosclerotic and osteolytic disease? Now, so if we put it down really simply, this is how you put it. If you get mesenchymal stem cells, they transform into osteoblasts, which then become active and lead to osteosclerosis. And tumors will either promote or deregulate that pathway, leading to osteosclerosis. Hematopoietic stem cells lead to osteoclasts, and osteoclastic activity leads to osteolysis. And some tumors will go down this route, so multiple myeloma classically goes down this route, resulting in osteolysis. But most tumors, most patients with breast and prostate cancer have osteolytic and osteosclerotic areas, and the balance between the two depends on OPG or rank ligand. So if you have more OPG, you tend to go towards sclerosis. If you have more rank ligand, you tend to go towards osteolysis. Now, that's a very simple way of putting it. There's a little bit more detail. And so this is the same thing, but just showing you a little bit more detail without showing you all the cytokines that are involved in this. Because if we start getting into that, we'll be here forever. So osteoblastic recruitment leads to osteoblastic differentiation, which then leads to the presence of woven bone within the marrow space. The woven bone becomes osteoid, osteoid attracts calcium, and then that leads to this osteosclerosis. And then you also see areas of osteolysis. These areas of osteolysis are caused by this pathway activating here, and then the OPG rank ligand ratio changes, and that leads to osteoclastic activation, and then suddenly you get osteolysis. Now, this is the same patient, except 1 year apart, right? So you can see that in 2014, he has a predominantly osteoblastic pattern, and in 2015, there's a predominantly osteolytic pattern. Right? Really interesting how this happens and how the switch occurs as patients go through their journeys. Okay, so it is these interactions that lead to distinct imaging phenotypes. And in fact, if you look at the imaging phenotypes on a bone scan, CT scans, and MRI scans, you end up with a number of different patterns, which I call, pattern 1, pattern 2, pattern 3, pattern 4, because it's just easier to remember. But what I want to show you today is pattern 5. So pattern 5 is the classical metastasis that one sees in breast and prostate cancer. And essentially what you have is a central area of mineralization and a peripheral area of osteolysis. And I just wanted to show you one example of such a patient. So if you look here, look at this lesion here. This is stir sequence. Difficult to see this metastasis on the stir sequence, but you see the halo around here. Can you see that halo? In fact, there's another halo here, another halo here, another halo here. Interesting. So what's that halo? Question number 1. Number 2, why do I not see this lesion, which is quite obvious on the T1 scan? Well, if you go back to the CT scan done on the same day, there's calcification in there. That's mineralization within the center of the lesion, which is leading to a reduction in the signal intensity. And similarly, if you look at this metastasis, quite a large lesion, front to back from that vertebral body, you'll see that although at the back here there's slight hyperintensity, here it's low, and it's low because there's mineralization in it. Interesting. So you can see how by looking and having the multi-parametric approach in this particular instance, just looking at T1, T2s and CT scans, you're already beginning to develop some sort of knowledge about what might be going on. Now let's add diffusion to it. So here is a diffusion scan in one of those lesions. And you'll see there's an anterior lesion, there's a posterior lesion, and in fact there's a dot in the middle of that, which is an area of calcification. So if you look at the CT scan, you'll see the anterior lesion, which is more mineralized. So here it is on the CT scan. You see there it is, more mineralized. That lesion has a slightly lower signal intensity, whereas this lesion here, which just has a dot of mineralization just in the center there, has this ring-like appearance. Now, some of you will say, I can't really see that ring, doc. Can you show that to me again? So if we look at this particular patient, you'll see this ring there. Can you see that ring? So here's a lesion which is osteosclerotic. You'll see the ring develops and then expands over time. Here's another patient here. You can see this is going to develop into a ring. Here is a patient who has a ring already. So this ring that develops around these lesions, in fact, represents the area of osteolysis. This is where the osteoclastic activity is increased, and that delaminates the bone, enabling the tumor to get larger. And that's why you see this. And in fact, on the axial images, you see a similar thing. Here it is, that this metastasis here is activating. You can see eventually develops a ring. So in the center here is mineralization. Here is an area of osteolysis where the tumor is growing. And here is another patient. There we go, a small area of mineralization right in the center. Peripherally, hypercellularity. That's where osteoclastic activity is going on. That's where the tumor expansion is going on. Okay. And you could show this, in fact, on animal experiments. So here is a metastasis, a tumor growing on the vault of a skull in a rat. There's the tumor, but if we look at this area here, and we're looking at the edge here, you'll see that there is this area of tumor growth. So this is adenocarcinoma, so you can see this glandular formation. That's tumor. On this side, you've got woven bone and osteoblastic activity, which leads to that darkening of that signal that I was showing you, the central dot. At the edge, you can see increased osteoclastic activity, and that's where the tumor expansion is occurring. Now, this is valuable stuff because you can use that to make treatment recommendations. And let me just show you one example. So here's a patient with breast cancer. You'll see that between this baseline scan and this scan here, the lesions have grown. And again, you can see these dots. You see central mineralization, peripheral hypercellularity, the lesions have grown. The patient is on ibandronate. So ibandronate is a type of agent that kills osteoclasts. So essentially, it's a poison for osteoclasts. And you can make the recommendation and say, look, this tumor is growing. You may want to think about changing the type of bisphosphonate. Go for a stronger bisphosphonate. So you can, in fact, intervene and say, try something stronger. Zoledronic acid would be something that was stronger, similar mechanism of action, but more effective, or something completely different, like denosumab. And in fact, the patient switches between and keeps the primary treatment going, but switches to denosumab, and look what happens. So that one responds, that one responds, that one responds, and that one doesn't. So this is heterogeneity in response. Okay, and we won't talk about how denosumab works, but essentially it's just killing the signal. The signal between osteoblast and osteoclast through something called rank ligand. So it's an antibody towards rank ligand. Okay, now, so we've now learned how multiparametric imaging tells you something really quite interesting about the bone, how it's reacting to tumor cells, about osteoblastic and osteoclastic action. Now let's talk about the therapy response paradigm. Now, here's a patient who has metastatic breast cancer getting chemotherapy. And there are some radiologists I've noticed in this room. So the physicists here don't have to answer this question. So chemotherapy, here we go. From between that and that, pre and post-treatment, response, stable, progression. Physicists don't have to answer, so won't tell. Okay, what do you think? Worse, better? Well, most radiologists would look at this and say, well, that's a bit more dark signal. That's probably tumor. Could be progression. This vertebral body here collapses. That's a significant skeletal event that would again go with with progression. Well, I'd say that was response. And some of you will say, what do you mean, response? Well, I look at the histogram, because the ADC histogram is very instructive. So here is a whole body diffusion sequence, and we just use 2B values, because we're covering the whole body. We can't afford to do multi-B value images. So here's the 800 image before and after treatment at the same time point. Here is the ADC histogram prior and current, and you can see the shift to the right. Now, this line here is the 1500 line, and in fact corresponds to this 1500 line here on this review article that was published many years ago in JCO. And the shift in the histogram represents death, that kill phenomenon. You kill cells, the histogram shifts. Okay? It does depend on how effectively you kill cells, of course, and we'll talk about that in a second. Okay, so nice example of cell kill. Okay, now look what happens to this same woman over time. Multiple examinations. You will see that at this point she's responding, continuing to respond in her marrow, but we have a lesion that appears in the liver, so we ablated that lesion. Waited another 3 more months. You can see the signal intensity continues to reduce. A new liver lesion appears. We ablated that lesion. July, so a year later, we have reactivation of the marrow. So that's interesting, right? So we've intervened while a major organ is responding by looking at using minimally invasive treatments for 1 or 2 lesions. Now, obviously we can't continue to do that forever. Now, if you looked at the histogram, so the signal intensity continues to reduce over time. The ADC goes up, as I've just shown you, and this is that 1500 line that I was talking to you about. But look at the histogram over time. That's interesting. It comes back down again. Not only does it come down and reduce in the median signal, it's actually flatter. So it's no longer ketotic. So Nandita talked to you about skewness and ketosis in the earlier talk. Here you can see that although the ADC comes down, it's much flatter, yes, and much less ketotic. So that's interesting. Why does that happen? Well, that's why we do multi-parametric imaging. You look at other variables that you have, and you can sort it out. So if you look, here are the 2 sequences that I showed you before, but over time, look, the fat returns. The increased water signal intensity between the first 2 examinations decreases. So we have a return of normal marrow fat, and we have dehydration of the bone marrow. Those are the 2 reasons why the signal intensity drops over time. Now, of course, and there's just to show you that example of the fat coming back. Now, you can measure fat, can't you? Yeah, we can do histograms of fat. So here, for example, is the signal fat fraction, which I call relative fat fraction. And you can see over time that the fat returns to the normal marrow. Right? This is repopulation by marrow. And of course, you can do a relative fat fraction image as well, quantification. And that's very easy to do, even for a whole body. And you can see over time, the fat fraction increases. And this is a sign of healing. So this is a sign of kill. This is a sign of healing. Again, interpretations that you can make if you had the quantitative data. Now, not all kill is alike, right? You can either do suicide or you can do homicide, right? You do suicide, only you die, correct? You do homicide, a whole bunch of people die, right? So similarly, if you were to go down the chemotherapy route, which is what I've shown you, you get cellular explosion, you get inflammatory responses, an increase in the free water pool, which then causes this dramatic increase in ADC, right? You kill 1 cell at a time, i.e. apoptosis. It's a very different mechanism. There is no inflammation, and the ADC changes are lower. And that's why it's important to know what the reproducibility is, because actually the ADC changes are not that much. So let me just show you an example. So this patient is getting a hormonal therapy. So classical apoptotic mechanism. Now, if you looked at the T1 sequence, you'd go, oh, I don't know, it looks about the same. Maybe it's a bit better. There's a bit more fat. Okay. By here, you'd say, well, that's probably a bit better. So how would this be read out? Yeah, that's a stable, right? That's how it would be read out. Okay, let's look at the diffusion-weighted sequences. You can see that the signal intensity is beginning to fade, but it isn't going away, right? And this is the balance that you're altering between repopulation and cell kill. Okay, and if you were to do histograms on this particular patient, you would see that there's a shift to the right, but this is that 1500 line, you see? It hasn't crossed that 1500 line, right? There's a shift and consistent with cell kill, but then look what happens. It begins to return and it's flatter, okay? This is some very nice software written by Robert Grimm, who's sitting in the corner over there. If those of you who are interested in seeing it, you can go to the Siemens booth and have a look at this software. It's actually a very, very nice software. Okay. Now, final example. Okay, let's look at this patient. So this patient has castrate-resistant prostate cancer, is getting treated with something called radium, a radiotherapy alpha inhibitor, which kills 10 cells. Hang on a minute, 10 cells? Well, when an alpha particle goes out, it kills about 10 cells, right? Because that's the distance an alpha particle will go to. Now, look at the stir sequence. Interesting, you'll see here to here, the signal intensity increases. Here to here, the signal intensity increases, but not that much. Okay, you think, what's happening there? This has been radiated previously, so this is the background fat. Look what happens. It increases. So if you were to look at the T1, you would say this patient is progressing. Except your oncologist is going to say, what the hell are you talking about? Look at the PSA value. It's gone from 1,000 to 150. This patient is responding. Right? So you are saying worse, and she's saying better. Who's right? Right? Interesting question, right? Now, okay, let's look at the diffusion sequences. Right. Now, if you look at the diffusion sequences, let's look at the MIP projection. You'll see that there are new retroperitoneal lymph nodes. So I win. I'm a radiologist. That's worse. Okay. You look at the prostate gland. You can see that there's more locally advanced disease. So again, I'm right. The lymph nodes are larger. You can see these nodes here are larger. So there is some progression going on, no doubt about it. But what about the bones? Well, look at the histogram. You think, that's interesting. So I've shown you this pattern. This is the third time I've shown you this pattern. This must be a response. So the patient is not only progressing, but is also responding. Both things are happening at the same time. Right? Now, that's not even the interesting thing. The interesting thing is, let's try to look at the dorsal spine and the lumbar spine. Why did we get this increase in signal? That means there's more water there. If there's more water, there's dead cells there, by definition. Right? So, is there a differential response going on here? Okay. Well, let's have a look. So here is the high B value signal intensity before treatment, and here it is afterwards, and here's the ADC. The ADC is low. Lumbar spine, progression. Dorsal spine, let's have a look here. Look, signal intensity goes down, ADC goes up, response. So both are going on. In the dorsal spine, the ADC has gone up, i.e., a response. In the lumbar spine, there's increased high B value signal intensity, and that's causing a reduction in the ADC value. So this is pseudo-progression, and this is true progression. So in fact, both the oncologist and you were correct. There is response going on. There is also progression going on, and it's happening in different places and different organ systems, and this is exactly what we expect to happen with castrate-resistant prostate cancer. This is exactly what happens, right? So this shouldn't come as a surprise to people who are clinically orientated and know this stuff, right? So why did we bother to do this? Well, the whole point of doing this stuff is we are trying to break the clinical paradigm. The clinical paradigm at the moment for bone disease is to say this patient is stable or this patient is worse. That's the clinical paradigm. In the bone, that's all we say at the moment in the clinic. What we can do as imagers is to break that bone into three categories. Not only can we say response, stable, and progression, but we can say this bit is getting better, that bit's getting worse. You see the difference? You are breaking this paradigm for bone disease from two categories into three categories. And that is key to changing how oncologists think. And if you change the way they think about their patients, they actually act in a different way. So what is the challenges for all of us in this room? The first thing is we need to understand the biology behind the image. Why do things look the way that they do? Instead of doing what we always do is describe it, understand the biology. The other problem is we have so many tests, we are getting different biomarkers, and actually that's a challenge for us. Yeah? How do you integrate these? And that's the bioinformatics challenge, and that's, these are things that you can write grants on, correct? How do you deal with heterogeneity? I've shown you one example of heterogeneity, one part of the body against another part of the body, but that changes over time. So that's another challenge. More grant money coming your way, okay? And as Nandita was saying, we need to standardize. We do need to standardize. We need to get beyond this point where I say my technique is better than your technique, because that's not the point. It's not the point. The point is, if we standardize, then we move into the clinic, that enables us to do validation. Right? That is the point. So for those of you who are interested in reading about this stuff, a couple of articles, and this is going to be the new standard for metastasis response assessment, which will be published in European Urology shortly. Thank you very much indeed.